Can all of you see my slide?
Yes, sir.
Okay, can I start my talk?
Yes, sir.
Yes.
Slideshow.
Thank you.
Slideshow.
I'll be
Please.
talking for 15 minutes on drug resistance in epilepsy. Seizures cannot be fully controlled in about a third of people with epilepsy, even though multiple anti-seizure drugs may have been employed singly or in various combinations. This phenomenon is drug resistance. There are four clinical patterns of drug resistance. The first one is the de novo anti-seizure drug resistance. The patient never enters the usual period of seizure freedom from the onset of epilepsy. From the beginning of diagnosed epilepsy, you put them on various medications, still they have some refractory or recurrent seizure in spite of all the medication combinations. Delayed resistance, which is when the patient initially becomes seizure free, but seizures recur and become uncontrollable. So initially they will be doing well. Then subsequently they'll be coming to the clinic and telling that I had a seizure last month, I had a seizure 2 weeks back, I had a seizure yesterday, like that. So we'll be wondering that why the patient suddenly becoming having recurrent seizure. So this is called delayed resistance. So one is the patient never enters the control, and the second one is a delayed resistance. The third one is a waxing and waning or fluctuating pattern that is occurs when the epilepsy alternates between being controlled and uncontrolled. There are period patient is doing extremely well. Then subsequently the patient is getting a recurrent seizure. So it fluctuates. There's a waxing and waning pattern. The fourth pattern is the epilepsy is initially drug resistant, but with time responds to treatment. So the patient may be coming every month and sitting in the OP telling that I had a seizure. Then we will be doing a lot of combinations, permutations with the medication. Suddenly the patient become well and the patient doing extremely well. So these are the four patterns of recurrent seizure, the drug resistant epilepsy you see in the clinical practice. The ad hoc task force of the International League Against Epilepsy, that is ILAE, defined drug resistance as failure of adequate trials of two tolerated, appropriately chosen, and used anti-epileptic drug schedules to achieve sustained seizure freedom. So the drug should be appropriate. We should choose the drug for the. That's why it's very important to label what type of epilepsy patient is having and choose the appropriate drug for the particular epilepsy, and use the proper schedule. And in spite of that patient not doing well, then it is become that is a refractory, there is a drug resistant epilepsy. In one study of 1098 adolescent and adult patients, the diagnosis of epilepsy was started anti-seizure drug and followed up for 20, and there is a median of 7.5 years. With first anti-seizure medication trial, 49% became seizure free. The second medication trial produced remission in another 13%. That is coming around, that is 49, then 62%. The third medication trial only another 4%. That's why that people say if there is a appropriate two drug trial, the patient still not doing well, then it become a drug resistant epilepsy because the third medication is only another 4% benefit. A review of 35 studies saw that the pooled prevalence proportion was 0.30 and pooled incidence proportion was 0.15%. So around 30% of the people with epilepsy have a drug-resistant epilepsy. The factors associated with the drug resistance are age at onset, that is symptomatic epilepsy. Patient has symptomatic epilepsy, they can become a drug-resistant epilepsy. Abnormal neuroimaging, abnormal EEG. So you find some structural problem in the brain and there is a gross abnormality in the EEG. Mental retardation, a neuropsychiatric disorder. These patients have a multiple comorbidities. Prolonged febrile seizure and status epilepticus. Somebody present with status epilepticus, patient having prolonged febrile seizure, they can become a drug-resistant epilepsy in the future. The single center 30-year longitudinal cohort study, one of the single center 30-year longitudinal cohort study found the risk factors are number of seizures occurring in the year before treatment started. The patient had multiple seizures before the treatment started. So one of the risk factors for DRE, drug-resistant epilepsy. Previous recreational drug use, patients are people using the drug abuse or drug addiction, and they have seizure. They also can become DRE. Family history of epilepsy in the first degree relatives. The patient, many people in the family have a seizure. They can become a drug-resistant epileptic patient. So these are the risk factors for becoming a DRE. There is a lot of economic impact on the healthcare systems because of drug-resistant epilepsy. Loss of productivity and employment. USA, the total cost was $4 billion per annum because of drug-resistant epileptic patients. Europe, the total cost was 15.5 billion euros per annum. So much of money is needed for treating these drug-resistant epileptic patients in developed nations like USA and Europe.
No.
So that's the mechanistic hypothesis of drug resistance. What are the mechanistic hypothesis of drug resistance? There are disease-related mechanisms, drug-related mechanisms, genetic mechanisms. All these may be interlinked. People can have more than one or two factors as a cause for the drug-resistant epilepsy. Among the various mechanisms that have been proposed, target hypothesis and transporter hypothesis are very prominent hypothesis. Most deeply explored theories of anti-seizure drug resistance. The target hypothesis and transporter hypothesis, apart from this, the other hypotheses are pharmacokinetic hypothesis, neural network hypothesis, intrinsic severity hypothesis, gene variant hypothesis. This is not only applicable to epilepsy. Some other hypotheses like target, transporter, pharmacokinetic, and intrinsic severity, gene variant are reasons for drug resistance, not only in neurology, also a factor in oncology. Some other patients do well with the medication, some people don't well with the medications. It applies to many other specialty. People are now, in the future, you may get some test where you can do the test and find out whether people will respond to the treatment or don't respond to the treatment. The four criteria for drug-resistant epilepsy are the mechanisms must, like postulate, be detectable in the epileptogenic brain tissue. The mechanism must have appropriate functionality. The mechanism must be active in drug resistance. The drug resistance should be affected when the mechanism is overcome. When we are able to overcome the mechanism, then the drug resistance should become better. The target hypothesis is occurred. Epilepsy-induced alterations to the structure and functionality of brain targets of anti-seizure drug lead to a reduction in their sensitivity to treatment. To exhibit anti-seizure activity, a drug must act on one or more target molecules in the brain. These targets include voltage-dependent ion channels, neurotransmitter receptors, and transporters or metabolic enzymes involved in the release, uptake, and metabolism of neurotransmitters. Based on studies with carbamazepine on voltage-gated sodium channels in hippocampal neuron, there are a lot of studies done on this hippocampal model where carbamazepine was acting. The transporter hypothesis is inadequate penetration of anti-seizure drug across the blood-brain barrier because of increased expression of multi-drug efflux transporters. It is postulated by Tischler et al. In 1995. Pharmacokinetic hypothesis is overexpression of efflux transporters in peripheral organs such as intestine, liver, and kidney decreases the plasma levels of anti-seizure drug in drug-resistant epilepsy patients. Neural network hypothesis is epilepsy-associated structural alterations, that is abnormal neural network, that reduce the efficacy of anti-seizure drugs. That's why it's very important to pick up the disease earlier, start the patient appropriate medication, and control the seizure. Suppose people don't take medication properly, having a poor compliance, getting intermittent seizure, the neural network change will become, the possibility of getting more neural network change is higher compared to the people who are having very good control and taking the medication properly. Intrinsic severity hypothesis is in drug-resistant epilepsy is inherent property of epilepsy related to disease severity. We know from the beginning this patient has a severe epilepsy because of so many other reasons. And epilepsy genetic association. Epigenetic hypothesis. Epigenome is a set of molecules that regulates the gene expression across the genome. Epigenome can be very dynamic, contrary to the other genetic things in the disorders. Epigenome can be very dynamic, varying even during short time periods and across organs. It's very dynamic, epigenome is. The other concept is neuroinflammation and blood-brain barrier dysfunction, which I explained blood-brain barrier dysfunction in the beginning. And neuroinflammation can be a component in many autoimmune encephalitis disorders or many other subtle inflammation which we are not picking up outside by various investigations. How to overcome drug-resistant epilepsy? Intra-hippocampal kainate mouse model of mesial temporal lobe epilepsy. So we have to have a specific models to check up whether the current molecule is effective against this kind of a drug-resistant epilepsy model. Intra-hippocampal kainate mouse model of mesial temporal lobe epilepsy. Lamotrigine-resistant amygdala-kindled rat. So the amygdala-kindled rat having a lamotrigine resistance. So the new molecule having mechanism is acted at a specific level. So we can find out, because apart from the different channels, calcium, sodium, GABA receptors, I think people are more focusing into the drug-resistant epilepsy. treatment, especially working on the different hypotheses which I mentioned initially. And chronically epileptic rat, they make they have a laboratory model of chronically epileptic rat, and they test the molecule. That will be more useful in the future, because no point in going on adding the same receptor, same channel acting molecules. We need to have molecules which are acting on the this kind of disease, drug-resistant epilepsy, which have different mechanisms. Several anti-seizure drugs targeting sodium channels are available. The identification and design of selective sodium channel modulators. Nowadays, people are talking about acting at a specific sodium channel, slow sodium channel, fast sodium channel, and people are talking about the epileptic area, modulation of epileptic area, neural network also. Reasons for uncontrolled seizures. One is the diagnosis is wrong. Second thing is treatment is wrong. Triggers and lifestyle factors like poor compliance, not going to bed in time, and drug-resistant epilepsy. So when you are looking for epilepsy which is not getting controlled, drug-resistant epilepsy, even though one of the reason, we have to keep in mind the diagnosis is wrong. Maybe patient having pseudo-seizure, treatment is wrong. Patient is on inappropriate drugs. Some drugs are not acting on some type of epilepsy. Some drugs will make some type of epilepsy worse. And triggers and lifestyle factors. Surgical options we know in drug-resistant epilepsy, and ketogenic diet for GLUT1 deficiency, which Mrs. Pazhani will speak. Pyridoxine for vitamin-dependent epilepsies. And by doing genetic test, we can find out whether any gene-based epilepsy is there. For example, SCN1A variant, oxcarbazepine, carbamazepine, and phenytoin should be avoided. SCN2A and SCN8A, these medications can be useful. So same drugs can be useful for this kind of genetic background, and same drugs will aggravate or may not be useful in SCN1A variant. And immunotherapy like autoimmune encephalitis presenting only as a seizure disorder or some kind of subtle inflammation, people are talking about immunotherapy because sometimes epilepsy can be due to some kind of immunological background. Conclusion. Drug-resistant epilepsy is a serious problem, constitutes 30% of people with epilepsy, and is associated with a mortality rate of 5 to 10 times that of general population. It's very important. Fewer than 1% of drug-resistant epilepsy are referred for workup. We know that we see these people in our practice sometime after a few years of treatment, then it will be difficult for us to control this seizure. And only few percent come for workup. Epilepsy care in a center is more than epilepsy surgery. Sometimes people think that patients coming for a referral setup, that they are coming only for epilepsy surgery. It's not like that. Epilepsy care in a center is more than epilepsy surgery. Drug-resistant epilepsy are responsible for 80% of cost of epilepsy. By reducing the drug-resistant epilepsy, by managing these patients more efficiently, by the data available, I think that we can cut down the cost factor of epilepsy at national. Thank you very much for listening to me.
Thank you, sir, for your precise lecture.